Greetings, everyone. As we say in the virtual world, good morning, good evening, good day, good night, wherever you're joining us from. Thanks for joining us for this conversation on sickle cell trait. I will start with the person I met last, which is Dr. Maisha. And I must tell her, she doesn't know who I am. She has no idea where I saw her. But a couple of things she said on three different webcasts I saw on. One is that sickle cell trait testing is futuristic, while sickle cell disease testing is looking behind. In other words, we need to plan for the future. And then this doctor goes into all these natural solutions. And on one of those websites, I asked her if she's really standing by those. She said yes. So I eventually asked her if she lives in the Caribbean, because the sort of thing she's talking about, I could only hear what I'm in the Caribbean. And since then, I've been following her. So I quote her, and we had a conversation last evening about sickle cell trait. And this leads me into the introduction to the gentleman who's sitting just next to her on this screen. I met Mr. Dozier last November. We were living on a virtual session, and we were all complimenting how all these men came together and talking about these personal stuff that mainly women will share on. I'm talking about really personal stuff. No one knew each other before. And then we reached out to each other. Mr. Dozier shared his life story at sickle cell trait, and it's something that I heard about in a very cursive way, without any depth, years ago. And it was just things that people would talk about in the fringe. No one went into details. When I met this gentleman, I realized that there are a lot of people that are quietly living with sickle cell trait, having amazing challenges and unable to talk about it. So I wanted to welcome Dr. Maisha, Farron Dozier. I call him Professor Dozier, so that's his problem. And in between them, there's a woman called Tamia Austin. It's difficult to mention these two folks sitting with us without calling that third person. She's not here, but her presence is felt. So I'll take you over to the host, Karen Blackman, but these two folks, Buckley's seat is a real intense flight. I hope you'll last it, because the information you can go with. And I wanted one last thing. Dr. Maisha makes it medical stuff so simple. I'm plugging you all, the host students, for the listening. Thank you for joining us.
Okay, so let me just tell you a little bit about our presenters. Farron Dozier is a retired sergeant, first class of the U.S. Army for 24 years, a veteran of the year in 2018 in Fontana, California. He's a sickle cell trait advocate, an arthritis advocate, a rhabdomyolysis advocate, a veteran suicide curriculum landmark education graduate. He's also into radio and TV broadcasting, graduated in 2015 and 18, a number of courses in academics attendance, right? He's also a radio and television host, right? And Dr. Maisha Pesante is a certified family medicine physician. For over 20 years, she has practiced the healing arts, becoming a certified massage therapist and herbalist prior to earning her doctorate in medicine at the University of Cincinnati, since completing the top-rated UNC Chapel Hill Family Medicine residency in 2010. Dr. Maisha has earned active licenses in many states. Dr. Maisha was a pioneer in the telemedicine arena, joining a prominent telemedicine company in 2016 and rolling out the telemedicine program at her clinic shortly thereafter. Her philosophy centers on creating patient compliance across a broad diversity of ethnicities and classes. She implements cultural sensitivity as an integral component of the therapeutic process. Dr. Maisha influences community health as a writer, on-air host, and public speaker, regularly featured on the KCAA radio show, What's the Count? She speaks on the on the sickle cell spectrum and related hemoglobinopathies that are under research and undertreated. Furthering her contributions, Dr. Maisha has held and presented 5 CME accredited courses on sickle cell trait and full spectrum hemoglobinopathies. These were presented at SCT 360 Full Spectrum Education in 2021. Based in North Carolina, she has cared for patients in the hospital, urgent care, clinic, and corrective medical systems. Dr. Maisha is also a philanthropist and community leader who champions the causes of the underserved and underinsured. Her contributions to medicine are crucial to the evolution of both the physician-patient and Eastern-Western medical relationships. Dr. Maisha heralds a refreshing, eclectic generation of physician leaders. Thank you. So I think we should be starting now with Farron.
Well, can everybody hear me?
Yeah.
Yeah.
KW, man, I appreciate you, KW.
Same here, man. Same here. Same here.
I love you, man. Thank you for that introduction. And it's been a pleasure from that moment we met on those virtual conversations. You and I have been connected. And he allowed me to use his straight talk. Shortly after that, I was on a virtual conversation and he created this straight talk. And I'm like,
yep.
how did I not think about that? So I said, please, can I use it, please? So I love that title because it is straight talk and it has some sickle cell trait talk in it as well. So KW, I love you, man. Thank you.
Man, thank you for the connection and thanks for deciding to join us. Really appreciate it.
And shouts out to my team, my without her and Dr. Austin, I mean, they bring this thing full circle and complete. So Dr. Maisha, thank you for taking your time to be here as well, because like I said, we're partners in crime in this conversation. So for those of you listening, as I said, I'm Farron Dozier, retired Sergeant First Class, and I'm here to share with you my experiences with sickle cell trait. So I have a presentation. It's gonna give you what I've been through and some basic facts about sickle cell trait. So let me get my screen going. Let's go here. All right. So again, Farron Dozier, retired Sergeant First Class, 24 years. And this is my sickle cell trait case study from my experience in 2006. And I hope you can see that. And I can't see my mouse, so here we go. If you're familiar with sickle cell trait, again, actually, this is World Sickle Cell Day presentation as well. So I'm going to give you some of the global conversations about sickle cell trait as well. So it is a global conversation. If you know about sickle cell trait, it has a purpose. We say it was created to combat malaria. And so as African Americans, we are number one. However, you have to know your bloodline. You have to know where your ancestors are from. So you could be Caucasian, Mediterranean, European, Asian descent. Right now, the Hispanic community is number 2 with sickle cell and sickle cell trait. So it is no longer just a color. So you have to know where your ancestors are from, and you have to have that hemoglobin electrophoresis test done to find out if you have a sickle cell trait. There are other types of tests out there, but we recommend the hemoglobin electrophoresis. So I could do a campaign for the next 20 years that sickle cell trait is not a Black gene, and we might be able to move the needle some in these conversations. So we need your support and your help and your conversation to help us spread this message as a global conversation. And then when we look at the numbers, sickle cell trait as a global inherited gene, 300 million people plus have sickle cell trait. And if you look at these numbers, which have been around the same spectrum, I would say, since the 70s and 80s, Nigeria leads the way with 300 million, and it goes all the way down to Brazil with 9, and Kenya with 5 million, Ghana with 4. And then the United States, they say between 2.5 to 3 to 4 million people have sickle cell trait, and millions still don't know. So again, this is a very important conversation.
Just bear with me. I'm organizing a send file for you, right?
Okay. We good? Okay. And
Yeah, I
so,
think it would.
okay. So this is global, and World Sickle Cell Day is our opportunity to make sure that we point that out, that this is a global conversation and it affects millions. Now, these are just people with sickle cell trait. Now, we have allies in our community, like C trait and D trait and OARAB and thalassemia, because there are people in our community who live with both sickle cell and a type of sickle cell disease. So if both parents have an inherited gene like sickle cell trait and thalassemia trait or C trait, then that child could be born with sickle cell SC disease. So I say that in this global conversation, we have allies that are the other red blood cell conditions that I mentioned. And so us coming together with this conversation just grows the numbers and grows the awareness. So that is very important. So this is my case study. This is gonna break down what happened to me that day, that perfect morning that I woke up in my 17th year at Camp Roberts, California, to do the exercise test. So it was Thursday, September 14, 2006. At the time, I was 36 years old. It was about 06:30 in the morning, and the weather was overcast, around 50 degrees. Now, I know I was dressed in my full exercise gear because of the temperature. So I had my shorts and tank and shirt underneath, my long sleeve jacket and long sleeve pants. So I was fully dressed, just so you know that. I was at my Master Sergeant Academy. I was at E7, working on my E8 rank. So when I completed this school, I would have been on the promotion list to make my next rank. And that was the goal, to have that education done. So when I was ready to get promoted in my career, I already had my education out of the way. As I said, it was my 17th year, and we do this exercise test, the APFT, twice a year. We do one for a practice, and then we do one for the official record. The exercise test consists of the push-ups, the sit-ups, and the 2-mile run. And at that age of 36, I had 17:21 to get a 60, which you need a 60 to pass. So that's all I needed, was to pass that test with the run with 17 minutes and 21 seconds. Again, that Thursday, September 2006, the clothing, I had a PT gear on, the jacket, sweatpants. I had completed the push-ups and the sit-ups. And the mental note I said is, we're trained to sprint that last lap. So as I'm out doing the 2-mile run, I come across that last lap and I hear my instructor, 15:45, 15:46. So I'm like, okay, cool. I'm in the 15s. So I'm like, I know I got 17. So I'm like, hey, I'm good. So again, we're trained to sprint that last lap. So my subconscious mind kicked in and said, let's get this over with, get your best time. And so I took off. And I did feel like electrical charge, like come over my body, like this buzzing sensation, but I didn't think about it. It was, me sprinting, and across the finish line was 16 minutes. And we're trained to put our hands over our head to get air in our lungs. And so I did those procedures as I came across the finish line. And as I started to catch my breath, I felt nauseated, like I felt weird. And then my body just started feeling weak, and like my knees and my muscles just started to feel like I couldn't stand up anymore. And then as I started to kneel down, my vision started to, like my peripheral got dark. And so I'm like, man, I don't feel well. And so I kneeled down because the nauseated feeling kicked in. And so I laid back on the ground, I closed my eyes. But when I opened my eyes, everything was spinning like a million miles an hour. So I closed my eyes real tight. The medics came and got me, and they rushed me to the local doctor in Twin Cities to get me some treatment. So they rushed me to the ER. Doctor takes me in, gives me an IV. He comes back within a few minutes and he says, you ever had kidney problems? I says, no. He says, what do you do now? And then he walks out. And I'm laying in the bed with this IV, like, what is going on? And my instructor's standing next to me, and I'm looking at him like, okay, what's happening? So he comes back in and says, you know what? It's a freak accident. You're probably dehydrated. I'm gonna give you one more IV, take the rest of the day off, and you should be fine. So I'm like, okay. So I take the IV, go back to the barracks. I wake up about 2:30 to drink some water, go to the bathroom, but everything was still, I got worse. Like everything was still spinning. I started to vomit, diarrhea, like I barely made it to the bathroom. I could barely walk. Nothing would stay down. I tried to drink water, Gatorade, eat a banana. Like I was in a very bad state. And so I just lay back down and I went to sleep. I know it was after 16:30 because class was over. My bunkmates came in the barracks and they saw me and they rushed me back to the hospital that night. So the night doctor took me in and he started to do some more tests. And the lab work that he saw was my creatine kinase levels, the CK levels. And at that time, they were over 12,000. And so the lab work that the morning doctor mentioned about the renal failure or the kidney issues, by the time I got back to the hospital that night, they were both about 50% each. So I was dying on the inside that whole day and had no idea what was going on. And so the night doctor, with those CK levels and my experience, there's a condition called rhabdomyolysis, which is a skeletal muscular disorder. So anyone could get rhabdo. It's not that it's particular to sickle cell trait. However, with sickle cell trait, we're a little bit more susceptible because of how rhabdomyolysis kicks in. And so with that rhabdo, when I overexerted myself, my red blood cells mutated, that is the S gene. And with rhabdo, there's no oxygen getting to those parts of the muscles. So the muscles start to leak enzymes and they're negative toxins. So there's a negative potassium that leaks out into the bloodstream and other toxins and myoglobin. And so once it hits the bloodstream, it starts to hit the kidneys. And so when it hits the kidneys, the kidneys can't filter those toxins. And so that starts the renal failure. So the morning doctor did see my renal failure, but obviously he didn't understand or was aware of what was going on in my body. Okay, so they ended up putting me on IVs for 4 days. And it was about the 3.5 day that I was finally able to get out of bed with enough strength to walk and literally pee in the toilet. So I had been peeing in that cup. If you've been in the hospital, I've been peeing in that cup for like 3.5 days at the mercy of the doctors and nurses who took care of me. My family came and picked me up because I could no longer stay at the course. And I went back to see my regular doctor to monitor my blood work and to see about my exercise. In 2009, after almost 2.5 years of trying to figure out what happened to me, and when I would go exercise and try to train again, my body would feel like I got off a roller coaster. Like I would get on the treadmill and do my walks and exercising, but I felt sick and nauseated after I got off the treadmill. And so we realized that I just couldn't run anymore. And so I was okay with that. And so I happened to be on the base one day because now I'm also dealing with my mental health. And I'm thinking that my career is over and all these different things that are going on in my life. And so I started to experience some minor depression and anxiety in my view. And so I happened to be leaving the mental health appointment, and Captain Adams was my platoon leader. So we served together in the war in 0405. We were deployed together. And so he was a platoon leader. I was a platoon sergeant. So we worked together and ran the company, ran our platoon together. And I hadn't seen him for 5 years. That was 2004, 2005. So I hadn't seen him in this is now 2010. And I crossed him on the base and he's like, how you been? And I'm like, you don't want to know. He's like, tell me. So I explained to him, my muscles, my joints. I can barely walk. Think I'm getting depressed because I don't want to do anything and I'm losing interest in things. And he's like, you know what? Something happened to me before where my muscles locked up, but I have sickle cell trait. So I have to drink extra water and take these vitamins. And I'm like, man, why does that sound familiar? And then I remembered in 1999, I took my second physical in the military. So I joined at 19. In 1999, I was 29 years old and I was transferring to another state. So I had to take a physical for that new position. And when I took that physical, the doctor called me back in a panic, like literally, like, you need to come back to the clinic. I'm like, okay. So I drive back and I'm like, okay, what's going on? Like, do I have something? And he's like, do you know you have sickle cell trait? I says, no. He says, okay, well, we just want to let you know that you have sickle cell trait. I'm like, hold on. I have a cousin, Nigel, with sickle cell disease. I don't have sickle cell disease. He's like, no, it's not the disease. You're just a trait carrier. You should have no problems. Just make sure you don't mate with another person. And I'm like, well, I'm done having kids. I have my 3 daughters already. So I'm like, I'm not worried about having kids. So in one ear, out the other, I never thought about it again. At 1999, I packed up my belongings and I moved across country, and I never really thought about it. But when he said that, I started to look in my life and remember these different episodes that I have had in my life. And so at that time in 2010, I was also diagnosed with arthritis. And so at UCLA Medical Center, I took that information to my rheumatologist, and she retested me and found out there was a positive sickle cell trait test. And then the information that I researched about sickle cell trait exertion with rhabdomyolysis, I was like, wow, this is what happened to me. And she was like, yeah. So she was able to formulate that packet. And in 2013, the military found me not fit for service, and I was medical retired. And that was definitely a life altering experience. My current age is 51. I still experience symptoms from that sickle cell trait exertion with rhabdo. And as I reflected back, um, with my experiences in 1975, I was 5 years old, and I remember my left arm aching like crazy. I mean, it would wake me up out of my sleep and I would be crying. And my grandmother would hold me over the sink and run warm water over my arm, only thing that would soothe my pain. So they took me to the hospital, to the doctor, and he told my parents and my grandparents that it was growing pains. He's 5, nothing to worry about. Well, my mom said that happened when I was 2 years old. So she said that since 2 years old that I would be crying in my arm and things like that. And, I would guess I could barely talk, whatever. But then that same pain that I've been having since 5 years old, at 51, I still have that pain to this day. It is a very uncomfortable agony. I mean, I wish I was a black Ken doll where I could just pop my arm off and put it on the dresser because it aches so bad. Now, again, remember, I joined the military at age 19, and my sickle cell trait wasn't found until 10 years after. So since 2010, I have been sharing this awareness because it is very important. I've learned that it's my gift. Like, we're all born for a reason. And I believe that this is my message that I was born to have and deliver. Most people, or a lot of people, have had sickle cell trait exertion and have died from that cause and from that experience. And so with the military today, we found that the Army specifically are now testing for sickle cell trait. I'm not saying that I caused that, but I could tell you that I have my foot on the gas. And so to hear that the Army specifically has increased their testing for sickle cell trait has been a blessing. And so I've been able to travel to this Camp Roberts where I collapsed at since 2016. And I've spoken to numerous amounts of veterans, military personnel who are in that leadership position to give them the awareness. And that has been huge, because since I collapsed in 2006, they had already been sharing my information that whole 10-year span. And then now I'm able to actually go in person and do that myself. So this conversation, again, is very important. I've met people along this journey who have had similar symptoms and similar experiences with rhabdo. So this is something that I've been blessed to focus on the risk factors. And so what I want you to take away, or what I want you to know about sickle cell trait exertion, is you have to know your status. I also met people with sickle cell, with rhabdomyolysis with thalassemia. So it's not just sickle cell trait that can cause rhabdo. Remember, anyone can experience rhabdo if you're dehydrated, if you are on a statin drug, can cause rhabdomyolysis as well. So knowing your trait status, whether it's sickle cell trait or thalassemia or C trait or D trait or E trait, that's very important, because as Dr. Maisha will get into, when it's time to start to have a family, and a lot of families did not know that they were sickle cell trait carriers when they had their children. Another thing that's important I want you to know is the asthma and the cardiac arrest that could be impacted and triggered by sickle cell trait exertion. Right, so that is very important. Acute illness, immune system. I met a Air Force officer who collapsed after his exercise test in the Air Force, and he knew that morning he had a cold, and he's done that exercise test before with a cold. But that particular morning, when he did that test, having a cold and exertion, his numbers were higher than mine, and he had to learn how to walk again because he had so much severe damage to his muscles and joints that he had to learn how to walk again from his rhabdo experience. And the only way they found out was someone told his wife to go look up YouTube. And when she did some YouTube research, she found and remembered that he was a sickle cell trait carrier. And that's how they started to treat him, like he was on dialysis. So it is very important for you to understand that sometimes it's not a good thing to sweat out a cold. Some people think you should exercise and, put all these clothes on and this sweatsuit and sweat a cold out. So that might not be a good idea for some of us. Lack of sleep. Some people that I meet, they say, oh, well, you know what? I have the trait, but I don't have any problems. I don't have any pain issues. I say, are you tired? Oh, yeah, you know what? I seem to be tired a lot. Yeah, well, you know what? For some of us, fatigue is a symptom of sickle cell trait. So dehydration, the muscles are weak. Dr. Austin, who's not here, but in her conversation, she shares that we're supposed to drink half our body weight in ounces of water per day. So if you weigh 100 pounds, you're supposed to drink 50 ounces of water every day. And most people answer that they don't drink that much. It is very challenging to drink half your body weight in ounces of water. But that's how you have to do that to avoid dehydration. So a lot of people are walking around dehydrated already, and then they want to go exercise. The nutrition, of course, diet. We know that diet is important. We know that some of the foods, the man-made foods, are not, the body can't digest those chemicals. And so those too can cause health issues. The medications, as I mentioned, side effects, the CK levels, the statin drugs can cause health complications and trigger some of these symptoms as well. And again, a medical examination, please, if you have a student athlete in your family, please make sure that they are tested for sickle cell trait or any red blood cell condition. Because as I mentioned, I met people with other red blood cell conditions that have had exertional issues exercising and being athletes. So it's not just sickle cell trait, but we are, focused on the sickle cell trait conversation here, but I'm responsible for these other red blood cell conditions. So I have to let you know that if you have other red blood cell conditions, to make sure that you have your child tested as an athlete, especially, or military as well. Or if you're just going to the gym to work out, make sure that you understand what's going on with your body. And it's not that you can't exercise, but you need a workout plan. Sometimes you have to make sure you hydrate and rest in between repetitions and things like that, and sprints. You might not be able to do 10 sprints at once. Maybe you have to do 7 or 8, take a break, and then do the rest. And so we're out making sure that the coaches and the staff of these athletes and military personnel understand that water is not weakness. And for some people, we need to be hydrated. And so it doesn't make you less of an athlete or a soldier. And I guess we're going to save some questions for later. But again, I'm blessed to be here to be able to share this conversation with you on pre-World Sickle Cell Day topic. And again, if you have any information or any questions, WDC on SCT.org is my foundation. The Farron Dozier Show, Dr. Maisha is on there. You can find all that out on the website. And I'll be here for the whole time. Now, let me see how I can, there we go. Stop the share. So thank you.
Should I, is the host going to talk next or?
I think you're just going to go right in.
Just go right in. Okay. All right. That was great. What brings us, greetings everyone. So our company is Inscription, and we're in partnership with the What's the Count, and I'm the medical consultant director for What's the Count, which I'm very proud to be part of this work. Farron recruited me many, many years ago, and I felt very shy in the beginning, but now I think I finally found my sea legs in this conversation, thanks to Farron and Dr. Tamia and then most recently, Ms. Richie Johnson with the Chris Johnson Foundation. It's been an amazing journey. There are a lot more resources out here now. I see we have about 16 participants, and that makes me very happy. And I want people to share this story with others. Everything that Farron talked about, we need to get the conversation out. The section that I'm going to present for everyone, oh, I did it in the backwards order again, is whether or not this is benign. I'm kind of going to go at it in conjunction with what Farron has already talked about in terms of understanding that this is not benign, and understanding the case report that he just presented to you, and that this is not as unique as people think it may be. So let me see if I can get my slides up for you guys. Let's see. So I have to share first, and then I can put it in present mode. Okay, so this is one of the classes we taught in our conference recently, SET 360, benign or not. This particular conversation really focuses on the interaction, which Ron touched on, between sickle cell and some of the other hemoglobinopathies. We coined the phrase that sickle cell trait and sickle cell disease, this is a spectrum of sickle cell hemoglobinopathies. It's full spectrum. And I hear people using that phrase now, and it's good. It's read quickly. And when I was like, well, you said it on an international conference, I hadn't thought about that. But you know, it's the conversation that we want to get out there. It's for people to begin to understand that these are not as unrelated as we think. I do have another slide that talks about the pathophysiology, but considering the story that Farron presented today, I'm going to go in for this one. When we talk about whether or not something is benign, benign means you don't have to worry about it. As Farron mentioned, the doctor told him, go home. You don't have to worry about it. But he did have to worry about it. So this first slide is helping people to understand things that can happen in sickle cell disease, SS, and in sickle cell trait, AS. And then later, we're going to talk a little bit about the relationship between sickle cell trait and some of the other hemoglobinopathies like alpha and beta thal are the two big ones. So on the outset, Farron described to you that he felt muscle weakness, and his status is hemoglobin AS. That's his genetic coding based on the proteins found in his blood on the hemoglobin electrophoresis. So very quickly, side chat, hemoglobin electrophoresis is how you can find out with pretty good reliability what your status is. If you're A, AS, SS, and then some of the other lesser known traits can also be figured out by your hemoglobin electrophoresis. The sickle cell spot screen or sickle dex, people don't trust it as much because it has a lot of room for false negatives and false positives. But when you're in the field, that's a good starter, you know. So you do the sickle dex, and if you feel like you have the symptoms, you can pretty much rely on the positive is a positive. If it's negative and you still have symptoms, you want to go ahead and still get the hemoglobin electrophoresis. And then there's something else called high-powered chromatography that's also coming down the pike as an even more reliable test. So the first thing is to get tested. But we know that Farron's status was AS. He's been tested more than once, and we know that that's a status. And even though he's quote unquote only trait, which is quote unquote benign, he experienced muscle weakness, which can happen in SS, pain, which also happens in SS, generalized weakness, which happens in SS, legs not being able to support the weight, which goes along with the weakness. He had his muscles looked and felt normal, but they weren't. Pain out of proportion to exam, very intense pain. And then some of the other things we didn't talk as much, well, he did talk about. He talked about his kidneys being involved in rhabdo. And that can also, that blockage, the muscles that are breaking down up here, causing all of these symptoms, is what causes that problem with your kidneys. And if it happens on a low level, that's not as dramatic as what Farron experienced, you can end up having something called pyelonephritis or a kidney infection, which also happens in disease. All of this can happen suddenly, and your urine can be abnormal, He told you they kept making him pee every day. They were checking his urine. It was abnormal. And abnormal means it's just not completely normal how it should be. Abnormal could be blood, abnormal could be infection, abnormal could be something called casts or evidence of kidney breakdown. So it was abnormal. Other things that happen in both: sudden and severe pain, which he told you he woke up in the middle of the night from the age of 2 with this sudden pain. It was so intense. It woke him up out of his sleep and he was screaming. Shortness of breath, which he experienced. Fatigue, which he talked about and explained that other people explain as well. Severe chest wall pain can happen in both. Headaches, fainting, which he experienced. He had the tunnel vision and he passed out. Severe cramping and inflammation. These are all in both. So this is a quote from one of the research doctors that I've been following his research and I have a lot of respect for. His name is Dr. Kabir Olinaran. And he has a quote in one of his articles: although sickle cell disease is more severe than sickle cell trait due to higher levels of hemoglobin S, they share similar physiologic mechanisms, a cascade of inflammatory effects caused by abnormal sickling of red blood cells in the microvasculature. This is slam dunk the money shot right here. This is a researcher who's been following the literature, who has very good and reliable research. People say we don't have enough research. We have research. The research is being dismissed or ignored, but we have research. He's saying, first, disease is more severe. Hands down, we know that it's more severe. Why? You have more of the offending agent, the root cause of the problem, which is this S, hemoglobin. And so if you come on some of our other webinars that are going to be coming up, the CMEs that we're going to be presenting in the future, the classes we're going to be offering and conferences we're going to be offering, I'll explain to you more about what hemoglobin S is and why it does all these things that we're saying it does. But he's summarizing that in a statement saying similar physiologic mechanisms. You have this hemoglobin S. It's a bad actor. It's not doing what it should do. It's the enemy at this point. It can be a friend with malaria, but all the rest of the time, it's pretty much an enemy. And it causes all kinds of inflammation. When you look at herbal and natural medicine, the root cause of all disease is inflammation. And herbs that help with inflammation, that's why something like turmeric milk or green herb, these types of herb combinations help with a multitude of myriad of diseases because they're addressing the root cause, which is something is telling your body to get inflamed, setting off more white blood cells, setting off more clotting, setting off inflammation. And so you get this inflammation and in the form of sickling. Sickling is the red blood cells that should be nice and round, like a fluffy pillow with like a donut pillow with a indentation in the middle where they can carry your oxygen very nicely and then fold up in the tiny vessels and unfold. Think about when you fold a pillow, folds as nicely. When you unfold it, boop, everything goes back. Not S. When you fold it, it's like folding together a grilled cheese sandwich. When you fold it, it's going to stick together. That's it. And trying to pull that bad boy apart is very difficult. And so that's happening in your tiny vessels. And the reason symptoms are everywhere, you have tiny vessels everywhere. Your entire body relies on it. They go into your bone. That's why you have bone pain. They're in your kidney, especially. That's why the kidney is one of the main places that sickle cell trait has a problem. And so we posit sickle cell trait is not benign. We have to stop saying that sickle cell trait is benign. At Inscription and What's the Count, we are getting the message out that this is not a benign problem. It may be silent for you or low enough of an actor that you don't realize what it's doing, but that does not make it benign. We cannot confuse silent in some on that spectrum with benign. And that's been the conversation for some very important reasons, which we can elaborate on as well in future classes. So what things make you go into a sickle cell trait crisis? Farron described several conditions that all were not in his favor on that infamous morning when he was trying to progress and thought he was going to that next level in his career and then actually lost, end up having to eventually retire from his career. Increased atmospheric pressure. Now that's one we can't necessarily measure, but that can be weather changes. Like when there's a storm, you can get increased atmospheric pressure. Low oxygen levels, like when you go high up in the mountains, when you exercise to exhaustion, which is what Farron did that day. He had already exercised a lot and done basically a marathon, and then he sprinted. And when he sprinted, that was the little bit over the edge. The body was like, you know what? We were rocking with you. We were making it happen. We were working around this S hemoglobin, but brother, you just went too far today. You just, we can't do it anymore. Sorry. And his muscles started to break down and all those things happened. Dehydration. I doubt that he stopped during that run to drink water. He may have hydrated the previous day, potentially, depending on what that day was like, but the day of, he did not stop to drink water. And I don't know what elevation level he was at, but that could have been a factor as well. So he brought as many factors together as he could. Another thing that's not here is high temperatures and low temperatures, extremes of temperature. Again, because that's affecting oxygen, that's affecting air, the hydration, that's affecting atmospheric pressure, extremes of temperature. So all that goes in there. He made all that happen infamously on that day. So I actually have some more cases to bring to the table with this particular conversation. So this is a case of a 38-year-old white female, and I picked her in part because everyone says flat disease. It can be anybody. These can be anybody. She used to be energetic and do a lot of stuff, but she has a total lack of energy as time has gone on. She's fatigued. Then she develops severe abdominal pain, severe leg pain and swelling. I need to move our gallery up here so I can see, or down there. Okay. Leg pain, swelling, and intermittent chest pain. She presents to her family medicine physician and says, I'm to the point where these symptoms are unbearable. I can't do basics. I can't take care of my children. She's been previously diagnosed that this abdominal pain was cholecystitis or inflammation of the gallbladder and had her gallbladder out. That did not actually help her pain. It stayed the exact same. She's been diagnosed with reflux, some early kidney disease. That's what CKD1 means. And of course, she can't exercise because every time she tries, the pain increases. So now she's obese and she has high blood pressure. When you see her on exam, she looks fairly normal, but if you press her abdomen, both the right upper abdomen and the left upper abdomen, that's what this severe RUQ, LUQ means, are in a lot of pain. She jumps back. However, you can't feel any enlargement of her liver. She doesn't have what we call an acute abdomen at that time. And then we check her extremities, and she has swelling, but they're not, you don't get an indentation. If you get an indentation, you think the swelling must be from blood pressure. So that's not explaining her swelling in this case. Also, we check for signs of negative McMurray's, means that her abdomen didn't show gallbladder problem. And then, I'm sorry, negative McMurray's in her leg did not show a problem with her cartilage in her knees or anything like that. In regards to leg swelling and negative Holman's, means we didn't see evidence that she was having a blood clot in her legs. We do her numbers, and she's mildly anemic. Her H&H is normal, but some of her other markers are abnormal. So this presentation is also designed so it can be taught to physicians, so they would understand all this kind of like alphabet soup I have up here. But basically, her hemoglobin and hematocrit, which is on one of the ways we check for anemia, were normal. So she looks like she doesn't have anemia. But when you look at some of the secondary checks, they're abnormal. Her blood also shows that it's smaller than it's supposed to be. That's what microcytosis means. And her liver is inflamed. We would have thought that that was gallbladder, but her gallbladder's not there. So that's ALK Phos is her liver. Her iron was a little bit low. Her iron binding capacity was normal, and her iron saturation was low, even though she was taking iron 3 times a day at the highest dose possible. She did show signs of inflammation. She does not have diabetes. Her urine was normal. We get the electrophoresis, and in her case, we don't find hemoglobin S, but we do find that something called her A2 is low. A2 measures the amount of alpha that you have in your blood. So in another class, we'll explain to you more about alpha, beta, and all that, what that means. But basically, this is very suspicious because she should have normal alpha. There's not a reason not to. That for me was the only clue I had that maybe she has something else that we're missing. So in this slide, I'm showing you that when we checked her spleen in 2019 and her liver, everything was normal. We checked again a couple years later, and now her spleen was enlarged. This is very serious. Now we're considering, is her problem, and we checked her legs and those were normal. Is her problem because she's deficient in iron? And that's what your doctor would say, prima facie, just looking at these labs, they're gonna say, oh, you have iron deficiency anemia. We're obviously not giving you enough iron. Let's throw some more iron at you and see if that solves the problem. But it doesn't in her case. Is it blood loss, or does she have something else? This woman was diagnosed with iron deficiency anemia. Even the hematologist said you have iron deficiency anemia because, well, she was white. She didn't know anything in her family history. But what we do find is small changes in the labs, small changes in the imaging that go along with the symptoms she's presenting. Iron deficiency anemia does not cause right upper quadrant and left upper quadrant pain. It does not cause swelling of your limbs, bone pain, fatigue, nausea, vomiting, passing out. It doesn't cause those things. It can only maybe cause the fatigue, but once you supplement with iron, that should get better. So she was diagnosed with that. She was prescribed iron for over a year. She did not improve. She was misdiagnosed. She's suffering and her spleen is enlarged. This becomes dangerous, and that's part of why we're doing this work. She has alpha thalassemia trait, a hemoglobinopathy. That A2 being low means she doesn't have enough of alpha thalassemia. Alpha thalassemia means your alpha chains are not working properly. One gene being missing is considered a silent carrier state, but she's not silent. Just like in S, hemoglobin S, this wasn't silent. This woman was very sick. She's having small blood. She's having a hyperchromic anemia. She's having fatigue, almost passing out, weakness, lack of energy, abdominal pain, joint pain. Tell me, guys, doesn't she sound like a patient with sickle cell? But she was told she's normal. In alpha thalassemia, iron supplementation causes splenic overload and sequestration of the iron, which causes your spleen to get big and then can cause your spleen to die off. Splenomegaly, just think about mega million. It means your spleen is too big, like the picture I showed you. And then it can die. And this is what's scary about this kind of misdiagnosis that's happening with trait and with the thalassemia community and some other hemoglobinopathies and even some other autoimmune disease like lupus and rheumatoid. So why do we care about thalassemia? Because it sounds familiar. It's inherited mutation of the alpha or beta gene, just like sickle cell is an inherited mutation of the beta gene. That's really what's happening, and it causes the same symptoms. It's a spectrum from silent to deadly, and it has an ethnic distribution, but it's not necessarily only one ethnicity. Beta thalassemia is the sister of alpha thal. You can't really talk about alpha without talking about beta. Beta is probably even a little bit more common. And same problem, you have a gene that's messed up. You have, in the case of beta thal, your electrophoresis is actually going to show a normal A2 or an elevated A2. And instead of a microcytosis, you're going to get a microcytic anemia. So you're going to have these small changes that the doctor can miss very easily. The key is to get your doctor to do genetic testing, which can be very difficult. There's a lot of misconceptions out there, incomplete misdiagnoses. And at the same time, a lot of the problems are the same. There's super S, which is S Antilles, S on man, and a few others that we're discovering, in which having just one S gene acts like homozygous state of SS. There's C trait, E trait, D trait. There are over 200 hemoglobinopathies. And another thing I've been teaching people, compound heterozygosity equals homozygosity, meaning if you have if you have S trait and you combine it with A or B, you are going to live a life the same as someone who has two S's. If you have S trait and you combine it with C trait, E trait, or D trait, same thing. If you have AS, but your S is a super sickler, you're going to live a life the same as someone with SS. And some of that can explain why people actually this is the slide showing that, why some of the people actually are living that life but getting missed. So you can have A plus S, and if it's Antilles, it's SS. S plus C, it's like SS. S plus beta, it's like SS. S plus alpha, and it's like SS. So this is a case where a patient had SC. He was not found out until he was 59. It's an African-American man who had bone death of both hips and a shoulder was in pain when I met him. He was told that his sickle cell was benign. I did his hemoglobin electrophoresis before his third big joint. You have only six really big joints. You have your shoulders, your hips, and your knees. Those are your big joints. And really your shoulders and your hips are the main one. And it's well known that in SS, your big joints die. Why? Because there's tons of small vessels there and they're clogged and the bone can't get oxygen. When it can't get oxygen, it's going to die off. So he was on his third big joint surgery when finally we did the electrophoresis and found out he's actually SC. You have to listen to the patient and have a high index of suspicion. Doctors have to listen to patients. We have to get your doctors to listen. We want everyone to help us promote these classes so that we can get into the medical schools, we can get before the residents, we can get before the nurses and start to correct the myths that are out there and save. It's not always about saving lives. I personally am obviously a woman of faith. I believe God decides when you die, but it's about your quality of life. That's what God gives you free will over. Are you going to be a good person or a bad person? Are you going to live a healthy life or an unhealthy life? And my job as a physician, entrusted with the highest importance in society, to teach and to maintain the health of people so that they can live the fullest life in the fullest of their purpose. That's why at Inscription, our motto is making whole human wellness a reality. Our charge with What's the Count and with Inscription is to help people live a healthier, fuller life so that you can raise your kids properly, so that you can worship properly, so that you can give back to other human beings properly and be in a good mood and be your best self and live your best life and give back. And so we're trying to get this knowledge out there. You know, you can have in hemoglobin S, it's one beta gene. So in AS, it's one beta gene that's messed up. That's what's the same thing that's wrong in beta thal. So if in one gene your beta is messed up from beta thal, and in the other gene your beta is messed up from sickle, that's SS, guys. And so that's why we're talking about this. It's easier to find beta thal than alpha thal because on your hemoglobin electrophoresis, your A2 will either be at the highest point of normal or it'll be elevated. Keep in mind the numbers can change because it's measuring the amount of proteins produced at that moment in time. So you could have, say, a 3.4, which is the upper limit of normal, or even a 4, which on some assays is the upper limit of normal, and then next time have a 4.4 or 4.2 or 3.8, but it's still beta thal. And it's confusing for the doctors. You have to have mercy on your doctors. We have been trained that sickle cell trait is benign. It gets said over and over. It was said again recently by a major organization in response to the discrimination for police brutality. So we have to get that message out there. So this is your hemoglobin electrophoresis, what it looks like. And you can see how the proteins pan out. This happens to be a normal one. And this is an explanation of the hemoglobin electrophoresis. But I think I should stop talking now. I feel like I've talked for a long time. We need to leave time for questions.
Yeah, that's fine. Make sure everybody they're on mute so we can hear some background noise back there, especially with my name on it.
Sorry about that.
No, you good. How much more you have? You got a couple more?
I think we're good. I mean, this is just explaining. This is kind of technical, explaining. I mean, if people want to understand, like if this is a question, we can kind of answer it as a question. As far as what the hemoglobin electrophoresis actually looks like, this is what this is what it looks like when they plate you out, and this is how the different. Where's my mouse? That's the wrong way. This is how the different traits pan out. And this is where they're getting those numbers from. And so it can change because it's just it's like something called collusion, where it's like a colloid effect where things have to ascend in the gel medium. Mm-hmm. And normal is most of your blood is A, 95 to 98%. A little bit is A2, and you might have a little bit of hemoglobin F, which is actually very protective. Which is why you didn't start having pain until you were 2, because that's about when your hemoglobin F or your fetal hemoglobin ran out. And so if you get persistence of hemoglobin F, it's really a good thing because it helps you with sickle cell.
I want to kind of touch on that a little bit more because I've met people who have sickle cell beta thalassemia or even SC, but their fetal hemoglobin is still there. So just say that again, just so in case people miss how important that fetal hemoglobin is a plus.
Fetal hemoglobin, it's very robust. It does a great job of carrying and delivering oxygen, ultimately. And so if you get something called persistence of your fetal hemoglobin, meaning so it's supposed to go away because you're not a fetus anymore. And it usually goes away around 6 months to 2 years old. It takes about that much time to run out. So you could even have symptoms as young as 6 months, but even for people with SS, a lot of times they don't start getting really sick until they're 2. And this is why, because they have fetal hemoglobin that's still around. And so if you have, it's not really normal for it to persist, but it can. And if it does, we're happy because it's a good thing. And so for some people, even into adulthood, they still have persistence of their fetal hemoglobin, and it works well for them. But so meaning if you have the S, like down here, that's supposed to be 0%, but it's 38%, and you have C at say 36, 39%, and then you have some A2 and some, no, those numbers aren't right. And let's say you have S at say 45%, and you have C at 35%, and then that's still wrong, 45 and 45. So let's say they're both 45, and then you have the other 10% distributed between A and F, your mate, that's lovely. So if you have 3% of this, A2, A2, and then 2% of F or more, that's going to protect you from this bad SCED or whatever else, you can have down there. Was that clear? I feel like I was confusing still.
No, that was clear.
Okay. Yeah, and so that's why over here I explained that under 6 months, it's 8%. So if you keep 8% into adulthood, that's going to help you a lot. And then I think the next slide just tells you some of the different combinations. This is just kind of breaking down some of the different combinations that people can have. And then when it comes to beta, you can have beta plus, beta not, beta minus. And there's so many types of beta you can have with beta thalassemia. And that can also impact how severe it is. But this beta plus is the most likely when it's combined with sickle.
I wanted to touch, since you're on these slides right here, Dr. Maisha, that here in the United States, newborn screening does capture some of these red blood cell conditions. However, like OARAB, there's some other tests that need to be done because the basic hemoglobin electrophoresis does not capture all of the red blood cell conditions that are out there. So
exactly, and that's what we mentioned here. S. Antilles and S. man and SO-Arab is the other one. SO-Arab, I want to say Arab. SO-A. I can't say it the other one. SO-Arab is the other one.
Yeah.
I didn't necessarily put here, but yeah, these are what you call super sicklers, super sickle hemoglobinopathies. They sickle at such a high level that one S alone it wreaks havoc on your body, and you can lose your spleen, you can lose your, you can have repetitive rhabdo, repetitive crisis. And so S. Antilles is named after us Caribbeans because some of the first cases of it were found in Caribbean people. So if you're of Caribbean descent, you have a higher likelihood of having S. Antilles. S.O. man and S.O. Arab is named after people in the Middle East. Because if you're from Somalia, which is Africa, but they have that, if you're from Somalia, Sudan, Saudi Arabia, all those quote unquote Arab countries, you have a higher risk of having S.O. man or S.O. Arab. And so this is, you have to be aware of that. But we don't test for it here. Yeah. We don't have those tests. These are laboratory tests. So if you're not part of a research study, it's unlikely you would be able to get these tests. We have enough trouble getting the genetic testing done if there's beta thal. It's like an act of Congress. And then when people get it, they don't even know how to read it. Right. I consulted with a lady the other day who had the test done. It clearly shows that she has beta thalassemia. When you look up what the genetic markers mean, that's what it means. And the doctor told her it was nothing, it was insignificant. And I just went through a gasket. My head just exploded. Like, are you serious? So we really have to change the mentality and start to understand that, you know, most human beings have some sort of genetic something, and it doesn't make us less of anything to know that we have this, but knowing that we have it, we can learn what to do to live a healthier life with it. You don't say someone with diabetes is weak, so let's not look for the diabetes because they're going to get discriminated.
Right.
You know?
And also, there's two things I want to touch on. And we also inherit 23 chromosomes from each parent. So you're going to
Correct.
you might inherit some other DNA issues that could trigger this complications of sickle cell trait. And so make sure you understand that yeah, we when we advocate, we want you to rule out your sickle cell trait to make sure that that's not what's triggering your health condition, because there could be something else going on that's your body is dealing with because of the other chromosomes that you inherit from each parent. So make sure you understand that. And then the other piece is, if you could touch on the C trait, right? And a lot of times people with sickle cell SC disease, because that C trait crystallizes. So we're looking at each one of these hemoglobinopathies, they react a certain type of way when you have that crisis. So the S we know mutates, but then that C trait crystallizes, which is a lot of times why those bones necrosis happens, because those C traits are crystallized. And a lot of people don't understand. They say SC is mild, but then we have to again be responsible for that language, because it's not mild. It's just a different type of sickle cell, and it depends on your body and how your body responds to it. And some people with SC disease have a lot of necrosis issues because that C trait is crystallizing. So one's mutating and then one is crystallizing. So you can imagine what's going on with your red blood cells. So
yeah, they're both mutations. And so one is sticky and stiff and clogging because it's sticky and stiff or folded over and not even, which is that sickle shape, and not even carrying any oxygen at that point. And the other thing that's happening is you're getting crystallization. So it's precipitating, again, not properly carrying the oxygen. So basically, we're talking about these S's and these C's. This kind of goes into one of the other classes. We kind of have to explain a little more, but your red blood cell has S and C in it. And so basically everything that's making up your red blood cell at that point is abnormal and has the potential to either get stiff and sticky or crystallize. And so that's why compound heterozygosity equals homozygosity, because you're combining it. And there's something else that you made me remember, but now I can't, it went out, so I'll leave it alone. But I think it's very important. All of these do something.
Yeah.
And the combination is very, very difficult to live with.
Yeah, very, very important.
Now, I thought I saw questions earlier, but maybe I was.
Yeah, there's a question. Someone is saying, I have been experiencing lancing pains in my left and right hands and legs, as well as extreme fatigue and lack of sleep, which has been affecting how I function at work. I had went for numerous tests, and no one seemed to know what the problem is.
What test did they go for?
They said they went for numerous tests, and no one seems to know what the problem is. I have sickle cell trait, and I was told since I was younger that it doesn't affect you. They have ruled out rheumatoid arthritis, and I have scheduled with another bone doctor for a visit. And they're asking now, how do persons with sickle cell trait with side effects of this, and with side effects like this in their everyday life, well, how do people cope with it, right? Is there any recommended medication that they can take to treat with the symptoms?
Oh, that's loaded. So as far as medications, you definitely need to have a primarily plant-based diet first and foremost, with lots of dark leafy greens. Obviously no pork, Limit your beef. You do need some lamb or beef for the B12 occasionally, like maybe once a month max. And you need to be drinking tons of water. You need to drink more than half your body weight in water every single day, and you want to get alkaline water. And coming down the pike, we'll be helping people with where to get the proper containers to help alkalinize your water cheaply, or at not that much of an expense, depending on how fancy you want. That's something that we're going to be we're working on at this point. But you want to drink alkaline water, and there's another slide deck that explains all that that I have. But I guess I should stop the share right now. Then you want to be drinking alkaline water. You want to take a type of green herb. It can be I like Green Herb by Green Vibrance. I have no stock. I get no kickbacks. But I think that's a good one that works well every single day. Turmeric milk can also help. And there's a supplement called cordyceps mushrooms that can also help with giving you the energy and helping with the fatigue. As far as Western medicine medications, yeah, not. If you can get someone to understand and believe you, what you really need is IV fluids, oxygen, and pain medicine from time to time when it's really bad. You can try 600 milligram ibuprofen as long as you don't have any kidney problems or contraindications to that. But it's a very serious situation because the medical world does not believe that this is a disease. Then there's no treatment. Even when you try to ask for the treatments that are available to patients with sickle cell disease, you will find that the doctors are unwilling to give you those treatments. So it's a very difficult situation. We are actively working on that at What's the Count, and with Inscription, looking for ways to make it better for people with sickle cell trait.
And I wonder if they need to get some more blood work to make sure those numbers that it's only sickle cell trait, because it could be something else going on. So you would definitely want to go back and get some current blood work done just to make sure that now you have information about those numbers, to have those A2s checked out as well. So that's unfortunate.
Yeah, it's better to get genetic testing because the A2 can be normal when in fact you have alpha thalassemia. I'm sorry, when in fact you do have beta or alpha actually. Depending on what's going on with you, you can have a normal and then it's just not showing up. Truly, with alpha thalassemia, I looked up to see the patient's A2 was decreased. But with alpha thalassemia, especially, pretty much the only way to find it is on genetic testing.
Okay. One of the interesting things was the question. I found out the comment was one of the things he mentioned was lack of sleep or problem sleeping, right? And I have discovered more recently, looking at some webinars of persons talking with sickle cell, that they have identified a direct link with sickle cell and problem sleeping, right? And sleep issues, sleep deprivation. So it's the question might be is if persons with sickle cell trait have that same issue.
Yeah, I'm going to assume from the pathophysiology, just like the quote we presented from Dr. Olinaran Kabir. I'm sorry, from Dr. Kabir Olinaran. You know, you always read their names backwards on the studies. So, you know, what he said answers that. And yes, we need the studies to prove it because everybody wants the studies to prove it.
Yeah.
But, you know, S is the bad actor, and there's S in both.
Yes.
So S is causing a lack of sleep in SS. Of course, it'll cause a lack of sleep in AS. Part of that lack of sleep is people are in pain.
Yeah.
They can't breathe. The temperature, the air might get thick in your house while you're sleeping. You know, it might be worth it to try sleeping with a fan on just so that the air keeps moving so that you can get the oxygen out of that air. You know, and that can be a catch-22 because for some people having the fan on bothers their sinuses, and you know, and so on and so forth.
Right.
But yes, I will find the research if it's out there to show the relationship between trait and sleep deprivation. I can't say I've seen a specific article answering that, but the pathophys says yes.
Yeah. So before I go on to some of the questions, let's see here. So why do you say alkaline water? I know we have a session on nutrition tomorrow, but
Oh,
why alkaline water?
I mean, the basic when I share with alkaline water is because alkaline water hydrates the cells, and that's what you want. You want those cells to stay hydrated. So alkaline, and then also with alkaline, the proper pH level, diseases can't survive in a proper pH level balanced body. So that reduces the white cells and things like that. So once you have your body balanced with diet and alkaline water or alkaline foods, your body is healthy and is regenerating itself. So if you do go into a crisis and you have a proper alkaline body, your recovery, it's not you're not gonna have a crisis, but the recovery process is where the value comes in at, because you're having the proper levels to restore the body. And you're not gonna get that eating man-made foods and McDonald's and Burger King. Like, you're not gonna get that recovery and the vitamins and minerals and enzymes that a lot of the foods don't have that we eat. So the proper pH level is very important.
I'm so glad you mentioned non-foods. I mean, obviously, I hope everyone knows at this point, you have to get organic food. Even your fish, you need to make sure they're making GMO fish.
Yes.
Salmon specifically, that grows double the size in half the time. That is not healthy. And you need to make sure that your food is organic, because God put factors and micronutrients in the food that helps with these diseases. I forgot to mention for patients with sickle cell or sickle cell trait, things like yams, your tubers, yuca. Yuca, what is yuca? Does anybody know what that is in English? Yuca. Yuca, is that the cassava? Cassava. Yeah, cassava. Those actually do help with sickle cell. Your sweet potatoes, but you can't put all the sugar and stuff. Eat them in a healthy way. And though now I've learned about this pink Himalayan salt, there's micronutrients. So you have to cook your food and make sure you're getting organic. We cannot eat at these places and think we're going to be healthy.
Yeah.
I want to go
all
back
my
to the
patients off of that stuff.
Yeah, I want to go back to water. Farron, you start with Dr. Sebi. You hit that fact. I mean, congrats on you. Rule of nutrition.
Yes.
You never said anything about that, right? I discovered that recently. But you guys talked about water having the proper source. So are you saying that you would drink the treated water that is done mechanically, or you go look for your natural water? What is the source of the correct water? I know you and Dr. Sebi talked about.
Dr. Sebi talked about spring water. Even with some people use the Kagan machine, and not to knock the Kagan machine that produces alkaline water, but he still says you don't want a machine making your water. So you want to get as much as, I think it's about 9.6 or 9.7.
Right. Yeah, that's what he said. Yeah.
Percentage of
that aligns with what Dr. Maisha is talking about now, in terms of the source of food.
Mm-hmm.
So if you're able to literally hunt down your water, hopefully grow and cook your own food. But can you expand? This is where Dr. Maisha confuses me, right? micro nutrition. Most medical people don't talk about that. What is your attraction in straddling these two worlds, and how do you talk to people, specifically sickle cell, be a trait or disease, about using these natural tools, as you said, God's tools, to engage a better quality life? How do you share that with your clients?
Oh, I mean, I'm me, so I just go for it. Like, all my patients know that, one, I'm going to try to get you off of these pharmaceuticals if I can, safely.
Okay.
Right? Sometimes
Really?
you need them, right? If your blood pressure is 210 over 120, I'm going to give you some metoprolol and be mad at you if you don't take it, but there are herbs you can use, like moringa seed. 2 moringa seeds a day will keep your blood pressure down.
That's the Caribbean right there. That's what I'm talking.
I'm definitely Caribbean. Que yo soy boricua, pa' que lo sepa, man. So, I mean, I am. That's my heritage. I learned herbs as a little girl, like growing up with my grandma. I learned about aloe for the kidney, and we ate cassava almost every day. Cassava, right? That's what the cassava, the yuca. You know, it's a normal part of our diet. So I think also for us in the Caribbean, some of us may not have symptoms as early as others because we're already eating all. It's normal. You know, fish and fungi is a normal breakfast, you know, and you catch the fish right there. So, you know, eating fish and greens, or kalalu, fish, fungi, and kalalu. I think I meant I was trying to say kalalu actually. You know, this is a normal breakfast for us. You know, we eat codfish constantly. Codfish salad and all of this stuff is our normal food. So I think when you being that now there's a lot more research to back up herbal medicine and herbal treatments. I started in herbal. When I started, you could not feed your family doing herbs, and no one believed you. Now you have the integrative medicine residency out in Arizona that popularized integrating alternative medicine with Western medicine. So now it's normal to integrate, you know, between the herbs and Western medicine, and no medical board is going to come after you anymore. It used to be you would be in fear of losing your license to explain some of these things. But you know, that's what we did a lot of work. We did a lot of work. We did a lot of studies that showed, hey, herbs do work. You have to dose them properly and all those things. I'm actually in Ibn Sina was basically the father of Western medicine. They call him Avicenna. They bastardize his name to Avicenna, but it's Ibn Sina. And I'm in the Ibn Sina Institute right now, getting my certification, my 3-year certification in herbal medicine. Because I've studied it, but I have my like certification from 30 years ago, but I'm getting a updated one now that I can add to my resume, so it makes it easier to say, here's how come I know what I'm talking about. But I already know it. You know it, I know it. We all know about curry sauce helping with inflammation. Like we eat curry. That's turmeric.
And that was one of the main things that, you know, Dr. Sebi acknowledged was he learned how to clean the blood of mucus. And that is the biggest thing.
I want to say one thing.
Oh no, this is an interesting pre-discussion for something that's coming tomorrow, because tomorrow we have
some questions.
tomorrow we have a national approach to treating sickle cell anemia with Tamika Mosley, and we also have a local.
Oh, Tamika, yeah.
Oh yeah, she's gonna give you some
Batson, who's into integrated holistic medicine.
Cool deal.
It's, it's going to definitely be an interesting discussion. Go ahead, Kyle.
So I just wanted to say that and this is just because I was so fascinated with the conversation between Farron Dozier and Dr. Sebi. What do you all think about continent relative diet?
Oh yeah.
Really?
Yes. Yeah.
And I've also heard you say, Dr. Maisha, that the Caribbean is probably better off than, well, I would use the word better off than.
Better and worse. Better and worse, because we have S. Antilles, which is worse.
But I'm saying in terms of what you have access to for nutrition, you're saying that
yes,
we have access to these things a lot easier than the continent, and we should be, we really live a better quality diet, even though we're not tested. I mean, you started one of the, can you clarify that a bit, please?
Yeah, so basically, one, in the Caribbean, it's much more open to that. Some of the good research and case studies have come out of the Caribbean, because it's much more open to realization that trait can make you sick. It's not, there's still some resistance, but there's a lot more understanding that it can, number one. Number two, our diet consists of curry, yuca, the tubers that help with sickle cell. A lot of the micronutrients that improve the function and health of your blood are naturally in the Caribbean diet. Also, it's, like, of course, Vieques got ruined with the military, and all the testing, but the water, like the Bahamas, the water there, what? It's so clean. The fish you're getting out of that water are healthier. Everything's great. You got mangoes, you got coconut. Coconut water helps your kidneys. You know, it's normal to just go get the coconut off the tree and eat it. You're not getting, the food is growing there. So the noni fruit, I remember noni fruit helps sickle cell. However, it's very hard to get the concentration you need anymore. You need 200,000 milligrams per 2 ounces daily, but you can only get 20,000 milligrams. You would have to drink 10 cups, a whole bottle every day to get enough. And that's very hard to do. It doesn't taste that great. But I'll give you a quick story. My grandmother had rheumatic fever as a little girl. She was about 15. And Allah subhanahu wa ta'ala told her, go eat that tree. Go get the fruit off of that tree. Wallahi, he told her, go get the fruit off of that tree. She went and got the noni fruit and ate it. Her fever went away and she came back to health. And she told me that story. From a little girl, I heard that story. And then when I got older, I found out that 2 ounces of the one that tastes like what you get in the Caribbean, which you can't find anymore. There used to be only one company that made it, only Natural Ink. And people have over harvested the noni fruit. So now it's hard to get the proper concentration. But if you're living, when you grow your food and you eat what's grown right where you are, all the nutrition is already in the food. When they pick the food all the way in California and they pick it too soon,
Ship it.
So, and it gets ripe in the shipping, it's not on the tree. It's not getting those nutrients from the soil. It's not respecting the process that God put it in. That was one of the miracles that, sorry, I'm getting a little religious now, that made us know Mary, radiallahu anha, was really a holy woman and the mother of Jesus, because when Zechariah came to visit her, she had summer fruits in the wintertime and winter fruits in the summertime. And that's an impossibility. Only the angels could have brought her that food because it's not normal. It's only been since the invention of the car that you can have a Florida orange in New York in the winter. And last thing I'll say, speaking of orange peels.
There's some questions. Mr. Blackman may go through questions. You'll take the questions.
Yeah.
You go ahead now.
Yeah. Last time she made us eat orange peels in the winter in New York, and we didn't get sick.
Orange peels. You really shot, but that Caribbean shot.
But go ahead. I'm sorry.
This lady is really special. So, so many questions. First one. Is there anything I can do for my children with sickle cell trait? It ends and alpha thalassemia trait in terms of specific vitamins they should take or a diet that they should follow?
Go ahead, Farron.
No, you got that one.
No, start with like the hydration, rest, respecting exercise, not letting the school take advantage of all that stuff.
Yeah, I mean, especially for the youth, again, hydration, the diet, the rest, the exercise. You still want to have all the functionability, but you also want to pay attention to their body and teach them how to pay attention to their body. I know my daughter, when she was having her crisis, I wasn't doing this work, and she had her hands and her feet and her shins ache, stress. So there are things in our environment that can cause it, but hydration is number one. Hydration is different.
Okay.
And doing the blood work to find out the iron, if there's an iron issue with the alpha thalassemia as well. So you want natural iron, nascent iron. I believe Dr. Sabi called it nascent iron, which is natural.
Yes, I think that's that program you did was, you need to probably document it. Lessons there are significant. Another question.
You can get
is
iron out of the food naturally by eating citrus with your greens.
But the thing is that he speaks about people with sickle cell trait using iron. Now that's counterintuitive from what I understand. I'm sure other people who live with sickle cell disease may or may not share that, but I don't want to go into that today. I want to get to the questions. Here's another question. Hi all. From UK, it's late here. I have SCT. I guess that's sickle cell trait. I am symptomatic been since age 5 and suffered the worst crisis of my life last year with ongoing complications, which resulted in mini stroke at the end of the year and heavy bleeding with huge clots. Currently working on healing my body with herbal supplements. I found out, one sec, I found out so much, and through having a good genetics counselor writing to me to my GP, that's my general practitioner, enclosed an official letter in my book, where she has a book, Symptomatic Life of a Sickle Cell Carrier and Invisible Disability. And Farron, you can relate to that, my story. It's available on Amazon and so on. So she just wanted to share, if anyone needs a support group, well, SCD patients need a support, search our group. So she's reaching out to the SCD community. I just want to go to another list of questions. So the first question on this side is, can you please tell me if there is a relationship between sickle cell trait and aplastic anemia? A good one.
Yes, if you get parvovirus 19, which is Fisch's disease, and you have sickle cell trait, you can end up with aplastic anemia.
Well, I just want to share that the person who posted this, I spoke to them today. And this is a big conversation. I know aplastic, you have to catch it early, right?
Say that again?
You must catch aplastic very early, is that correct?
Yes, it's very, very serious. It's deadly. It's very serious. And so you do have to protect your children. Is that the person with the children? Because this disease is flat cheeks.
Yeah, I think so.
No, the person with children is from the UK. This is from
no, that's the person with the hands, actually.
Yeah, the person who had aplastic, they're local. They were asking that question, but they do have children.
All right.
Okay, so the question is,
They
do you have
aplastic
international?
now? You said they have
No,
it
they
now?
have this. No, this was in the past. They were just sharing their story, right? Do you have international patient consults, or would you do it if you don't have it? This is both of you.
Absolutely.
Yeah,
Yes,
that's what she's setting up.
yeah, we're setting that up. That's a service we're gonna offer and subcontract with What's the Count. We're gonna do international consultations. We will do all kinds of consultations. Consultations will not be a doctor-patient relationship in the beginning. It will purely be educational. And it'll be limited what I can write for you. So in the beginning, what I can do is offer education to say, yeah, that sounds like what you're going through is related. It's not. You're not crazy. I don't understand those results. Ask your doctor this question, that question, or that question to get more to the bottom of what you're dealing with. But in the beginning, we have to be careful with the consultations, but we are accepting consultations. You can go on inscription.com and you can book it yourself at your convenience. The schedule is there.
Can you put that website in the chat, please?
Oh yeah.
Yeah, so they can see it.
And the main thing, you know, I've been advocating for it almost 11 years, and the main thing is being able to arm our community with questions, right? And if we can arm them to go back to their doctor to get more specific.
Oh, I see.
And you know, until we can actually take care of, you know, possibly one day take care of them.
Yeah, pray for us to get to the point where we can.
The next question is from Ayana Paul, and she says, I have been diagnosed with trait. I struggle with anemia, and although I take iron supplements, my iron levels are still low. I was told that my body is not absorbing the iron as my B12 is also low. Can this be as a result of trait, or is there anything I can do about it? That's from Ayana.
Yes and yes.
Okay.
Yes and yes. So more than likely it is trait because, well, what I suspect is alpha that it's you know, that's a setup for the case I presented.
Yeah.
What I suspect is alpha thalassemia.
Wow. Okay.
Yeah.
And so why iron can be dangerous in sickle cell trait. Your red blood cells, when they break down, they release iron into the system, but it's not usable. It's floating, and it can be sequestered in your spleen and make your spleen enlarge. And then your blood's already sequestering there, making your spleen enlarged. and it'll just pop if it gets too large, and you'll lose
Okay.
it, or it'll die off. And so it's not good to keep throwing iron if it's not working. More investigation needs to be done. It just sounds like the doctors don't have this on their radar as a possible reason why the iron is not changing, because it's your body can't process, it's not processing these things correctly. It's probably in alpha thalassemia, microcytosis means you have an excess of cells.
Yeah.
So you're making more cells, and those cells are using up that iron, but the cells don't work.
Okay.
So the iron's not out in the circulation, it's inside of these useless cells, these red blood cells that are defective and not working.
And one thing I really haven't touched on from my own experience, when I used to go to the VA, my doctor would be in a panic because my bilirubin numbers would be like, you got liver disease? I'm like, I don't have no liver disease. What are you talking about? So she would make me fast to come back to see if my issues with my liver. And again, I wasn't doing this work until I became an advocate and started to find out that could be those dead red blood cells that she had noticed, because I was exercising. Like I said, I had been exercising since I've been in my career. And so, Dr. Maisha, do you want to talk about the bilirubin counts? Because
yeah, it's the same thing we were just talking about pathophysiologically. The red blood cells are also breaking down faster than they should. Some of the studies are now showing that even in sickle cell trait, the life of the red blood cell is shorter than the normal life, which is 4 months. And so that's happening because they're breaking down too fast. When you break down a red, that's our first lecture I didn't do today. Where they break down too fast. But essentially, the short of it is they break down too fast. It releases biliverdin into the circulation, and that biliverdin stays out until it can be uptaken and put into a new cell. Well, you can't make your cells fast enough, so it's for that time. It won't always be up. It'll be up and then go normal, up and then go normal. It'll flash up and then go back normal. Because when those cells break down, boom, everything's breaking. It's too high. You can't work with it. Then your body recuperates and uses it. And like in the case of alpha thalassemia, make too many.
I'll read one more question and then I'll refer to Mr. Blackman. This is from Sasha. She says, is there any evidence with how it can affect patients diagnosed with or NCD tissue disorders, ND connective tissue disorders? So is diagnosed with ND connective tissue disorders.
Uh-oh.
This is ND tissue disorder means
Connective, and that's what I'm seeing here. ND connective tissue disorders.
yeah, that means we don't know what it is, so we're just gonna call it connective tissue disorder. But we gave it a fancy name, so the patient can say, we can tell the patient we had a fancy name for it. So like, meaning I think they're talking about connective tissue disorder, NOS, meaning not otherwise specified. So it's like, we think there's some problem in your connective tissue, but we don't know what it is. It's not lupus, it's not rheumatoid, it's not Sjogren's, it's not anti-SS, it's not anti-Ro. The ones we can identify, all those are no anti-smear. It's not all centromeres, all those are normal, but you're having pain in your connective tissue, but it's also in your bones and your joints, connective tissue is all over, your pain is all over. So that's when it's basically lazy doctoring, or it's not on their radar. They've been trained sickle cell trait is benign, so they're not even considering that your problem is your sickle cell trait. Yeah. They're just diagnosing you with something else. It's like saying fibromyalgia. Mm-hmm. I have sickle cell trait patients that have been diagnosed with 5 things: chronic fatigue, chronic pain, fibromyalgia, rheumatoid arthritis, lupus, atypical. Because there's no proof of those other things, but they don't know what to put. Yeah. I'm sorry. It's just one of my pet peeves in medicine.
This aligns with something that you said in past, treat the client, not the...
Treat the patient, not the numbers.
Right. Okay.
Treat patient,
Mr. Blackman, finish your questions.
All right, well, we just have two more. So, will the slides be available more so for the blood work figures of the different categories of FCD? Well, of SCT. Well, the presentation, you should be able to get it on our Facebook, on the SISBD Facebook page. So you can always review the recording, right? So, and the other one is what can be used to treat kidney disease?
Kidney disease. I need to hurry up and get this.
I'm telling you.
La hawla wa la quwwata illa billah. There's a lot that we need to
That's not an easy question. That's not.
Yeah, this is not an easy job. Kidney disease is another wastebasket diagnosis. It simply means that something in your kidney function is not normal. Usually it means that your creatinine or your GFR are abnormal. Creatinine is a measure for how well you're processing your proteins. So is GFR. Creatinine being elevated means too many proteins are spilling out that your body should be keeping in, and it cannot. GFR is your glomerular filtration rate, which again says how well are you filtering your proteins and other nutrients that the kidney is responsible for, maintaining the potassium, there's hydrogen, other balances of electrolytes, sodium, chloride, magnesium, phosphorus. Your kidney is responsible for balancing all of these things out. It's part of the responsibilities in conjunction with other organs and bone. So basically, kidney disease from what? From sickle cell trait, from diabetes, so with kidney disease, you have to find the source of the kidney disease and treat that. Number one. Number two, if you have idiopathic kidney disease, which a lot of people with sickle cell trait whose kidney disease is caused by sickle cell trait will be told that they have idiopathic renal failure. And they'll be, they'll say, oh, Black people have more renal failure. Some of that is sickle cell. So, and you can look at Dr. Kabir Olinaran's work. He does a lot of work around the kidney.
Can you type that name in, please?
Dr. Kabir Olinaran.
Can you type the name in? Okay.
Type it. Oh, okay, that. I don't know this guy. I don't know this gentleman, but I'm a fan.
I want to drop some information because as I've been advocating and meeting people with sickle cell trait, there's, like I said, we inherit so many different, 23 from each parent, right? And I've met people with this glucose deficiency who were sickle cell trait carriers as well, called G6PD, and it's a glucose 6 phosphorus.
Yeah.
It's not a glucose deficiency.
It's popular.
Well, I'm just saying it says glucose. That's what it's a
G6PD. Yeah. G6PD.
So I've met people with sickle cell trait that have that as well, and there are medications. There are foods that you cannot take, fava beans, and there's certain beans and medication. And I know that because when I started advocating with my military community, I've had friends who said, oh, I got sickle cell trait and G6PD, and I found out when I came off of deployment, they put me in this room, like 4 of us, and they gave us a brochure and said, by the way, you got G6PD. And I'm like, why, what? So my advocacy work is to give you the facts about trait, but to also let you know that there are other things, and we don't want to blame everything on sickle cell trait. At the same time, you want to rule out your trait, and we want to arm you with this knowledge and information, but there are other things that you've got to also focus on your health to make sure that it could not be sickle cell trait, or it could be triggered. The trait can be triggered by these other things. So I have friends who have this G6PD that pass out and they have no idea why they were fainting, right? And so there's so many things about our health, especially with men's health, that we have to address. But G6PD is a glucose, and these are the things that when you start going back with looking at your health, ask your doctor these questions. Can I get these exams? Can you do this test? Just to start ruling out these red blood cell conditions, because they can be secondary health complications.
You will need to come back. You all need to come back, both of you. Last time he came alone, I don't know why I didn't bring you. I want to take 5 seconds
Okay,
to
5
recognize Moape Miller. I didn't recognize her text because it's coming through Farron Dozier. It shows how connected the sickle cell trait community is, which is what we need to do with sickle cell disease, because Moape is from the UK. And it's probably 1 o'clock in her space or close to AM, that is. And she's here with us. She has a book. Her website is MWAPE. That's her first name, Mwape. MWAPE, last name Miller, oneword.com. So I just want to recognize her for joining in from the UK, taking time from her needed sleep, you know, and she's following us here. Welcome, Mwape.
Yeah, thank you.
And her book is amazing. Symptomatic Life of a Sickle Cell Trait Carrier. So everyone should get that book. And we have to support her, and we have to support each other in this work.
Yes.
So it's very difficult, but we have to do that.
I'll share something else about coconut water that is widely known, probably because the research was done in Nigeria. But it was shown that coconut water actually helps prevent or inhibit the hemolysis in the red blood cell.
Wow, I did not know that about coconut water. You just taught me something.
Coconut water
That's awesome.
itself increases the nitric oxide content, right? So it's interesting.
They had to find one that tastes good.
And so the question about kidney disease, that's one of the things that coconut water, aloe vera juice, noni juice, those all help. As far as
There's a
treatment.
gentleman on here. I don't know if you'll say anything, but he is the first person. Now, I've had coconut water all my life. Fortunately, I live on both islands. Dr. Maisha is from the Caribbean, you know, Trinidad and Tobago. So I used to be in Tobago.
You're a Trini.
Yeah, I'm from Trinidad and Tobago. And this is the source of this webcast today. Is the organization is located in Trinidad and Tobago, and I met Farron in the US. I'm meeting you now. Amazing. So I've grown up drinking coconut water, and I joined this organization 7 years ago. And this gentleman, I just call him Mr. Esdale. I just call him Professor Esdale, and he talks about our founder. Farron heard me talk about her, Dr. Waveney Patricia Charles. I have to slow down and call her name. Dr. Waveney Patricia Charles took coconut water and tested it because of the results he got with his children. So what Mr. Blackman is talking about, whilst people are now running to it, these two people, but he listened to the doctor. Dr. Charles always said,
Put those names in the chat. Those doctors.
The American Society of Hematology would know of Dr. Charles extremely well. She's deceased now, but they know. And if Mr. Esdale wants to jump, I don't know if he'll say anything, but I will tell you that he introduced me to the validated coconut water locally. He talks about it. He still treats his family regularly. So anybody who's here and can get some coconut water, especially as Farron said, it's really good. Not the ones in the bottle they put in the grocery, right? Buy the coconut vendors and buy it. Like me, fall from a tree and pick it. I'm happy that Mr. Blackman mentioned that.
No coquito. Coquito is ruined with the rum. You can eat coquito and coconut water. It's not the same.
So let's hear from him because he is.
I don't know.
Somebody needs to mute.
That she's got my name on there.
No, that's Leah. Leah, you need to mute, honey.
Somebody needs to mute themselves. There you go. Thank you.
There it is. Okay, now.
Mr. Esdale?
That's Leah. She's another warrior. She started a Facebook support group for people in Baltimore and Maryland.
Are you hearing me, Kyle?
Yes, we are hearing you a lot better now. Remember, in this environment, I'm KW, right?
Right. Sorry.
That's okay. That's good. Then.
Coconut water issue. I mean, up to every Wednesday, when I buy 10 liters, and I have it frozen in BPA-free bottles, right? And we use it every day. The children. I mean, it happens with me, my kids, both sickle cell disease, SS, and when they become very yellow in the eyes, and I know that their bilirubin level was high, I just decided I wanted to try something. So I went out and I bought fresh coconuts and gave them that in place of water and other liquids. And I would discover the next day that the urine will get very dark and the eyes will get very clear in a short time. And I did it numerous times and I realized, well, look, this thing is working. So I spoke to Dr. Charles and told her this was my finding. She told me, well, it's not doing him any harm, continue to do it, and you will discover sometime what is going on. And then many months after, she came and she said to me that she checked it out and the electrolyte level and a lot of what is posted in that article Kieran spoke about in Nigeria, she told me too, and she did a checking on the coconut water. So I wanted to tell Kieran to share that article with the two foreigners so that they could read it, because it kind of, the English kind of a little broken in it, but the facts, the science in it is very good. Okay, Kieran?
Yes, it's a difficult read because of the broken English, but once you get through it, the information is really good. It's really critical, and it's not just sickle cell. It also talks about other uses of coconut water, but it really explains how coconut water can help sickle cell disease, and hemolysis is, well, preventing the hemolysis is just one of them.
Can you guys please post the article for me?
Sure, yeah, we'll do that.
Oh,
It's a Nigerian study, and it was peer reviewed. So you know, it has some basis, some scientific basis. But I am sold on that, and nobody's going to get me to stop doing that. You know, giving my kids coconut water, everybody who have the trait, because I have one daughter with the trait, and I have two with the SS, and I am sold on that. I'm sorry, because it really works. It works. I saw it work, and eventually, many months after Dr. Charles told me, he says, I checked it, and it is scientific. It works. So it come like you're taking your IV through your mouth.
Yeah, we need.
yeah.
Which just like the Thai coconuts, the young coconuts. Which coconuts from where?
The young one.
The ones from
Young
each,
ones.
that's from the bottle.
Yeah, I don't have a tree now. I'm in the U.S.
Not the patented one bottle. The ones that I got were the ones that I go and I go to the vendor. He chops them open and fill them into bottles for me, because I can't do that at home. I don't have a wherewithal to do all that. And I bottle them and freeze them and use them every day. We use about, I would say probably about 2 liters a day home here. 2 liters a day. So in 5-6 days we knock over, you know.
One thing I could definitely say from experience that I mean, I don't have a crisis very often, but when I do, if I take pain medication with coconut water, it works a lot faster. Definitely.
Yeah.
Definitely.
You only need to publish, but it's this going to scientific review. No longer. I want to say something about Mr. Estelle, and he's off camera. He likes the background, but from listening to this organization, and by extension, this gentleman specifically, as another gentleman I asked to sit in, Mr. Virgil. These both men do two things to me. They show up and they show that men take responsibility. They are not the popular kinds, but they, in my mind, they are the most common, but they're not popular. So most people think that those that don't take their responsibility, they're the most common. That's one. And Mr. Azil, again, and Mr. Virgil, they represent the benefits of paying attention, listening to your doctor, making decisions for your family. So I call him Professor Estelle because he's a professional caregiver. Him and his wife have been able to raise 3 children, as he mentioned, and for the most part, healthy. And, you know, we who are now, I'm a newbie in this organization, and they have battled throughout 3 decades to ensure that the people who are engaged in this organization, if they listen more so to Dr. Charles, but more importantly, use the information, the results can be optimal quality life. So what you all are bringing to the table today, I don't cook You all are foreigners, no longer you all. I mean, more after lean more to Dr. Maisha because she has the.
All right.
Oh my God, right.
I'm not offended. I'm not offended.
You know I
You
love
see
you.
what
Right?
I got behind me? Do you see what I got behind me? I'm not offended with that. Do I need to move out the way?
I know. That will all connects us. That always connects us. It's straight
No,
over.
I
This is
definitely wanna say thank you to both of you, to Farron and Dr. Maisha for this really informative and interesting discussion we've had this evening. You know, there are a lot of doubters out there when we tell people what we've learned and
Tell them what last night, Kieran.
right.
Tell them what last night.
Yes. Well, no, I wouldn't say that in this public forum, but
No, say it anonymously. Say it anonymously, please.
okay, we met with a group last night and they were doubting that sickle cell trait causes symptomatic issues or even death, sudden death, right? And they were shocked. They couldn't believe, right?
Strong
and they had to report to the professor.
Kieran, can I make a point, please, Kieran?
Yeah.
I felt very good when Dr. Maisha said when she spoke about the tuber, cassava and yam and
Right.
And I particularly remember Dr. Charles telling me through the years the benefit of these root crop in the Caribbean and how our patients will do so much better if they become, more attached to those kinds of foods as against eating fried potatoes and that kind of thing. And hearing her say it tonight now was kind of refreshing. It's kind of like we were hearing Dr. Charles again, and she can't understand why people in the Caribbean are anemic when they have callaloo bush and they have bhaji and all these green stuff that they could eat. She can't understand why anemia is a problem in the Caribbean unless there's some real problem. But normally people shouldn't be anemic. And if we eat the root crop, it's so much better eating the root crop and all that kind of stuff. And then I realized that she was saying to me the ethnicity of food. I don't want to go there yet. That's another discussion. People from our ilk, have to probably attach to a particular kind of diet that match our genotype. I don't know that, but Dr. Maisha, you will probably be more acquainted with what I'm talking about there. But there's a point she made to me all the time. You understand?
Yeah, Doctor.
Well, I want to invite there's Mr. Blackman's forum, but Mr. Blackman, forgive me if I'm not supposed to, but I want to invite Dr. Maisha and Farron to come back to our caregiver session to Lyme this time. What the word Lyme means, he learned that when he met me. But we're having a caregiver and we want to be holistic. So we're talking about all the different methods. And Dr. Maisha has said before, my confusion with you was all this medical information and you just slant straight into natural stuff. And you were talking all around the world and she's holding on to her. That's the last thing she said is the thing she said most vehemently, most strongly, most intensely. And people got very quiet because, and I kept saying, I tied us up. Yes.
Wait, what did I say that people got? Wait, what did I say that people got? What did I say? I don't.
You were talking about all the natural things like the moon and so on, and you're speaking to people from a varied continental background. A lot of medical people sitting there as well. And I tried to ask if you sure you want to hold on to that. And you said yes. And then you went, then she exploded. And then somewhere along the line, I asked if she's Caribbean. She said yes. And I stopped asking questions because I know the basis of it. So, to hear all this connecting now that we have a lot of our solutions on the ground, in the ground, but it's going to take a while to really, twist even the mindset. And that's why
that is something we're definitely going to explore tomorrow because it's something that I've asked.
Yeah. So please come back.
Yeah, it's the mindset.
I hope it's okay.
KW, you said it. You said it right there.
I will invite the two of you all to follow same time tomorrow because we have that discussion with Tamika and our local person here, Dr. Batson, right? So tomorrow same time, right?
Thank you.
Change your
Well,
schedule, you know.
thank you for joining us. Thank you for being part of our Connecting the Dots web series, right? And thank you for making this all a success.
Hey,
Before you
World
end,
Sickle Cell Day.
do you all, like Farron pulled on, you know, who held on to straight talk, connecting the dots, and there's another person I speak quiet, it came up with some, it was designed by someone called Gillian Brussel, who's on tonight. But you all understand that what you are talking about tonight is connecting all those dots that are never connected.
Mhm.
And without if I didn't say it tonight, then the relevance of the topic wouldn't connect to the information.
Mhm.
And Ms. Russell doesn't know what she said when she said that, but I'm sure it was inspired by the creator, like you said, Dr. Maisha. So we came and connected all those dots. I mean, we can take each component that you all have talked about today and create and flesh out an entire session again.
Yes.
So
Yes, that's what we need to do. That's
I'm gonna
what-
mute myself.
You good, KW? Thank you.
Yeah, you're wonderful. I do have to go. I didn't even realize the time.
Yeah.
But I'm thankful. You know, when we talk about the inspiration from the creator, today is one of my clinic days, and I normally don't finish until 9:30. And I somehow finished early enough to get on here. I was shocked. So I intend to do the same tomorrow if possible, because I'm in clinic again, but I will do my best to be here. And I feel the spirit of it wrapping all through us, and a lot of things are falling in place.
Yes.
And I feel so at home. You know, my grandma passed, and just listening to you guys talk, like I miss my grandma so much right now. But I think the goal is to change the mentality. And if we can stay unified and supportive of each other and keep one voice, that's how change happens. Think globally, act locally. And that's what we have to keep doing. So I'm very honored that you guys have included me in this and whatever expertise I can bring to help the community.
And for me, before we go, it's not a competition thing. Sickle cell trait has its own awareness, education, and prevention. Sickle cell disease has its own awareness, education, and prevention. These conversations come together when those two parents have that child with that inherited gene. So I know there are some people in the sickle cell community think that we are trying to change their. It's nothing to do with you at all. If anything, we're helping you understand, because some people with sickle cell disease felt that when they had their children, oh, my children's not going to have any pain issues. My child's not going to have any issues because they're only going to have the trait. Well, guess what? You might have to be aware and understand that if you have a child and they're going to be S trait regardless. So, or C trait, depending on what genes you carry.
Yeah, sure.
It's not a competition. This is about having the 300 million people plus globally understand and get the awareness of the gene that they carry. So
Right.
we are not trying to take over the conversation. We are adding to the strength in numbers, and we have our own awareness, education, and prevention for sickle cell trait, and we're here to make sure that that conversation gets had.
And we are stronger together. And if anybody wants to consult, they can just go on the website if you want to have a private conversation and get some education.
Yeah.
Mr. Blackman, can you allow me to remind Farron of two things, please? I'll try and take this to this. Is that okay?
Sure.
Okay. Farron, you and I discussed without know the trait, you'll know your fate. Remember that?
Mm-hmm.
Know the trait, you'll know your fate. And secondly, there's no disease without trait.
Exactly.
No one more important than the next. I mean, so I don't know if you've taken out of your artillery, but without trait, there's no disease. So as I would say openly, trait is more important. We must find out where the trait lies.
Yeah,
I know
appreciate
that conversation in the past.
We'll have more. Thank you.